Thank you so much. I really appreciate it. I'm Eric Gantwerker. I'm going to be talking about Stridor for the ENT resident and what's that sound and where is it coming from. Again, I'd like to just acknowledge the initiative at the University of Kentucky and the department for sponsoring this, and I really appreciate having us on, and I think everybody is really getting a lot out of this. I do have some educational technology consulting affiliations. None of those have influenced this talk at all. I do like to try to do my talks as much as I can about as a discussion and getting as much involvement as possible and always allowing questions, because I think that is where all the learning happens. For this talk, I'm really going to describe the difference between Stridor and Stertor. I was going to have people list out some of the causes of Stridor in infant, and we'll talk about that, and describe the natural history of a child with Laryngomalacia as being a very common cause, and explain the workup and treatment of a kid with Stridor. So usually I open it up to the floor to find out what people know about Stridor. If there's people on, I encourage you to either use the chat function or you can just say it out loud. I encourage participation, so you don't need to be muted unless you're in a busy street corner or ambulances are rolling by, or if you're whistling Dixie. Whatever participation I appreciate. If anybody has any thoughts, please share them now. If not, we'll just move forward. One thing that I do need to do is, Sarah Lynn, can you hear the volume here?
Do you have sound going right now?
Yes, can you hear it?
I can, a little.
Okay.
Yeah, I can hear it. I can hear it.
Soft. Might be a little soft. So oftentimes, as an otolaryngologist, we often get these calls or consults for children with Stridor. And when I see some of these patients, this is sort of the sound that we hear or gets described. And oftentimes, because any noise that people hear coming from the upper airway or the lower airway, they universally use the term Stridor. And one of the biggest takeaways from here is to realize that when people say Stridor, they don't always mean Stridor. They mean, I hear a noise that I don't think I should be hearing. And for us as otolaryngologists, I think one of the biggest differences is between this sound and what truly is Stridor. If anybody on the call knows what this is, please feel free to speak up. Really what we call this is Stertor. And what this is this is sort of a snoring respiration that is almost strictly upper airway, and oftentimes can be delineated from Stridor. And the reason why it's important to understand the differences between what you're hearing is because the etiology of what's going on will differ based on what the sound you're hearing. So we'll talk about the different dynamic ways that you can hear Stridor and how that will give you a clue as to where it might be coming from and ultimately what might be causing it. So oftentimes I ask, what are you hearing? And this actually is a true Stridor sound. So this is Stridor, and oftentimes we discuss about dynamic versus static Stridor, and where this might be coming from depends on what sort of phase of breathing it's coming from, as opposed to this one. So I encourage those who are watching this after the discussion to really think about, what are you hearing? What phase of breathing is this in? Is this inspiratory, expiratory, or biphasic? And I'll play it one more time. Whoops, let me go back. So one thing that I always see with ENT residents when they're first starting out and they're evaluating children with Stridor is almost universally they say, oh, it's inspiratory Stridor, it must be Laryngomalacia. And as specialists, I want us to move past that. What's most common is always what's present. And I think you should critically figure out what phase of breathing it is. And I'll tell you some pearls as we go on as to where that can actually get you in trouble. Again, I encourage you at home to think about, is this inspiratory, is this expiratory, where is this? As you can see, this is most likely lower airway. And this actually is an expiratory stridor, or oftentimes we call it a wheeze. And this can be seen in certain different clinical diagnoses, which we'll talk about a little bit later. So why does the noise happen? This is really integral for everybody to understand why stridor happens. And the key to thinking about this is that stridor, stertor, wheezing, and murmurs all have the same etiology. And if you understand why it happens, it makes it a lot more easy to understand why it's happening in your patient and what are some of the causes. And really, when it comes down to it, what is the actual underlying cause of all this? And it comes down to turbulence. And usually I have somebody explain to me what turbulence is, but essentially what it is this disorganized flow of molecules. And the best way to experience turbulence is actually through a water hose. And the way that I describe this is, as you put your finger over the water hose, you are changing certain physical properties about the flow of water that causes it to become turbulent. And if anybody's on right now that can tell me why does it become turbulent, you'll get major bonus points. But essentially what happens is, because flow is constant through the tube, otherwise water would back up in the tube, that as you maintain the same flow and you narrow the opening, you are actually causing a increase in velocity of the water as it passes through that narrower opening. And to maintain flow, it has to go faster. So molecules per time, increase pressure, so that one of our audience members increased pressure. So that's a good thought. So what actually is happening is there is increased pressure at that choke point, what we call. And what's actually happening is that you have to move the molecules fast to get them and the way it's described is we'll get when things are flowing easy, they and as they go through the narrow points, they actually will cause more turbulence. And as the turbulence actually evolves with this idea called the Reynolds number. Carolyn, are you able to me for some reason moving forward?
I'm sorry?
The meeting dropped me.
Yeah. Dr. Gantwerker? We're kind of losing you again. We can see your screen, but I can't hear you. We can hear you.
Can you hear me now?
Can hear you, yes.
Okay, so I don't know why that is happening.
No,
hopefully it won't continue.
Okay.
Okay, so why does turbulence happen? So essentially what happens is that things move from laminar flow, which means nice or evenly organized, to more turbulent flow when you get to these different choke points. And what it comes down to is this idea of the Reynolds number, which is something that you hearken back to your physics days, which a long time ago. But essentially one of the biggest things you'll see is what determines whether things are laminar flow or turbulent flow is the Reynolds number. And the lower the number, the more laminar the flow, the higher the number, the more turbulent the flow. And one of the things that you'll see is that increases directly the Reynolds number is actually the velocity and actually the inside diameter. So the inside the diameter, obviously the less of a point and less the velocity has to go through that area. And so as the velocity increases through that area, it's more prone to turbulent flow. And that turbulent flow, when turbulence happens, actually creates eddies and creates noise. And that noise, when you're in the airway, is respiratory noise. If you're in the heart, that is heard as a murmur. And you can see as the diameter changes, that actually the Reynolds number changes. And we'll talk about how diameter and resistance actually work in conjunction. And that's called the Poisson relationship. And this essentially says that the flow is proportional to 1 over the resistance, and resistance is proportional to 1 over r to the 4th. So as the radius increases, the actual resistance goes down to the 4th power, which means that radius and resistance have a very strong relationship. And even in little kids, where just a small little bit of narrowing happens, the resistance increases tremendously, which is actually a resistance to flow. And as the resistance to flow goes up and the diameter goes down, the Reynolds number goes up, and you're more prone to turbulent flow. And that's why in those different wheezing and stridor and stertor and murmurs, you hear noise, is because of turbulent flow. Otherwise, it would be relatively laminar flow. This also works in the converse. So if you can just increase the radius by a very small percentage, you actually have a great effect on the resistance and dropping the resistance and improving flow. And this choke point we can see in all different kinds of human systems. And we'll talk a little bit about that. So where is the narrowing happening? This greatly depends on a bunch of different factors, but oftentimes what you'll get clues on is how the stridor is happening, what phase of breathing it's happening, and how it changes. And we'll talk a little bit about that. So again, for the people in the audience, I encourage you to tell me, what are you hearing and what phase of breathing do you think it's happening? Your options are inspiratory, expiratory, or biphasic, meaning both during inspiration and exhalation. I'll play it one more time. So most people will recognize this as stridor, and it's inspiratory. So you can notice when the kid breathes in, you can see that he's working muscles in his chest. You can see that he's tugging. He's working really, really hard when he tries to breathe, and it's all inspiratory. And so this is actually the most common form of stridor. And oftentimes I ask, what information do you want to know about this patient? If anybody's on right now, you can use the chat function. I'm not going to use the poll system, but think about what types of things you would ask this mom about their child. And oftentimes, following that, you do a physical exam. So what are some high-level clues? So one is the patient age. So age and onset are extremely important for stridor, because especially in infants and neonates, the timing of when this starts is extremely important. For kids that have had stridor, quote unquote, since birth, which is a very common thing that parents say, or as long as I can remember, those causes are different than, oh, on Tuesday, he started having stridor, and this happened right before it. So getting the evolution of the noise is going to be really, really important. When did it start? How has it changed? What's making it better? What's making it worse? All of those things give you clues as to what might be going on. It's really, really important in kids, much more than adults, to figure out what is the medical history of the patient. Were they born early? Were they on a ventilator? Have they been intubated? Have they had surgery before? Oftentimes, even kids who have had surgery and have been intubated for short periods of time can have stridor that actually caused from a reaction to the tube, even if for a short period of time. How do they look? I always tell my residents that when they're going into a room with a kid with stridor is to get that gestalt of what's going on. For most kids, I can tell within just a few minutes of being in the room, even sometimes a few seconds, is this an emergency? Is this really bad? Or is this kid relatively stable? And that I think you get over time as you experience more and more kids with stridor. And then really the sound characteristics. What is this, dynamic or is this static? And we'll talk about that. What phase of breathing is it happening? All these types of things you really want to understand. I also really get a lot of history about how they're feeding, how they're gaining weight, Are they feeding okay? Are they coughing, choking, gagging? These are all questions that I ask to try and get a better understanding of their ability to coordinate their suck, swallow, breathe reflexes and their ability to eat. And really understanding the OPQRST, which is what we used to have. I think there's a different mnemonic now, but knowing what's making it better, what's making worse, will give you a lot of interesting information, how bad it is, whether the parents have ever had to call 911, if they've ever brought them in. There's an old term called ALTEs, which I think are now called BRUIs. ALTE is a parent life-threatening event, and BRUI I think is now a brief respiratory something. I can't remember what BRUI is, but somebody can Slack me or send me a message to remind me. But so have they turned blue? Have they had problems breathing to the point where the parents had to bring them in? Is this getting better over time? Is this getting worse? And like I said, a lot of different things about their birth history is really, really important to really get a better understanding. Are there concerns about syndromes? Are there concerns about neurological tone? Are they hitting their milestones? These are all important things. So one of the things I want you to notice is their work of breathing. The biggest thing that I see ENTs have over the people who consult us is we separate the sound from the severity. I think it's really important to separate those two things because the sound can be very, very harsh sometimes and be impressive. I've had parents tell me, you know, we bring our kid to the grocery store before COVID, and parents always say something to me about my kid's stridor and, well, you should really get that checked out. And I've seen it on the floor where patients with stridor, often croup, are getting taken care of. And oftentimes they end up treating the sound instead of the child. So the child's not having any distress, is breathing just fine, eating just fine, gaining weight, but everybody gets concerned about the sound and they start treating the sound, and that's where you get into trouble. And we'll talk about that a little bit later. The phase of breathing is one of the more important things for you to assess because it gives you a clue as to what level this is actually coming from. And oftentimes we say that inspiratory stridor comes from the pharynx and supraglottis. If it's in the glottis or subglottis, or sometimes even in the upper trachea, it can be biphasic. And if it's down in the lungs or the intrathoracic trachea, then it can often be expiratory stridor. And this has to do with the pressure that somebody had alluded to before within the system. And also it has to do whether the problem is dynamic, meaning it changes with the phase of breathing, or it's static, meaning it doesn't change regardless of the phase of breathing. And that's a really important distinction for you to understand, because then it gives you a better clue as to what might be going on. If it's dynamic, it'll either happen during inspiration or exhalation, or if it's static, it'll most often be biphasic, because regardless of which way the air is flowing, you are getting the sound, you're getting the turbulence, you're getting the narrowing. So to sort of elucidate this, we talk about the top 3 causes of stridor in infant. If anybody has any thoughts, feel free to use the chat function. Oftentimes, laryngomalacia is probably the #1 that most is on everybody's head. And just like everything that wheezes is not asthma, everything that has stridor is not laryngomalacia. And I'll show you some cases where people got into trouble thinking that it was just laryngomalacia. The next is subglottic stenosis. So subglottic stenosis can either be congenital or acquired. And bilateral vocal paralysis, I think, is the one that most residents sort of forget about. And we'll talk about the bilateral vocal paralysis. So again, I encourage you to think through this. Is this inspiratory, expiratory, or biphasic? I'll tell you that this is actually an inspiratory stridor. And oftentimes that comes from the supraglottis. And the reason why is because in order for air to get into the lungs, you have to create a negative pressure. And that negative pressure causes airflow through the glottis and supraglottis. And if there's any neurological issues, any tone issues, any anatomical issues, what ends up happening is the supraglottic structures actually get sucked in through the Bernoulli effect, which we'll talk about. You didn't know you're going to have to know so much physics through this, but it's more just background information to help you understand what's going on. You don't have to remember everything. But because it's dynamic, it's only during inspiration, it's because that negative pressure is actually sucking in those supraglottic structures. And when they exhale, it actually blows all the structures out. And so you don't hear any stridor on the outside because that diameter is now greatly increased because all the structures that were blocking it are now removed. And so that is why it's a dynamic inspiratory stridor that's often affecting the supraglottis. Now, this is anything that affects the supraglottis, not just laryngomalacia, and we'll talk about that. Laryngomalacia, I'm not going to spend a ton of time on. I think this is probably the #1 thing that most people see. If you see on the scope exam, you can see an infantile epiglottis, meaning it's sort of folded in on itself. The area epiglottic folds are very narrow, are very short, and you can actually see a band of tissue that's actually pulling the arytenoids forward. Sometimes you can have laryngomalacia where the epiglottis is primarily causing, and sometimes will even fold into the larynx. Sometimes you can actually see that it's just the arytenoids. Sometimes it's a combination of the two. Really, when it comes to laryngomalacia, this is the kids that parents will often say it started since birth. Really, it's supposed to start shortly after birth, within a few weeks. It does actually get worse before it gets better. And I'll explain that why, but eventually most of these get better with time. And the biggest thing is, when do we need to see them? And for me, I have my own beliefs, which we'll talk about. So the Bernoulli effect. So it used to be a way to explain how airplanes lift off. We've since found out that that's actually not how they lift off, but it's a good way to understand it. And so the Bernoulli effect is that when pressure is differential, and you're actually having having a faster airflow, that actually creates a negative pressure gradient and actually creates a suction effect. And that's what's happening in the larynx. So why does it worsen initially? This really comes down to sort of the respiratory needs of the infant. And oftentimes I have you guys tell me what you think, but oftentimes it does worsen at first because their requirements for minute ventilation go up before their larynx can catch up in size. And so you actually have a demand problem, a demand and delivery problem. And that peaks around 3 months of age. And like I said, just small changes in the radius can have drastic effects on the resistance. And so if there's actually an increase in flow without an increase in radius, you are creating a very narrow point and a need for faster airflow through that area. And thus you'll hear the stridor. Now it does get better because eventually the larynx catches up in size. And as the larynx catches up in size, it's able to keep up with the demands, and you no longer have the stridor. And we'll talk about that. So when do they refer them to us? So for me, I often think that most kids who are really not following the expected pattern of recovery, meaning that they are getting better with time, or they're not having increased work of breathing, or there's no other etiologies that may be considered. For me, I like to see all these kids. I scope most everybody with laryngomalacia. There's a lot of differing opinions out there, and I'm sure a lot of people watching this will have differing opinions as to how to work this up and how to manage this. And the example I give was, this was a 5-week-old that I saw that was being followed by the pediatrician for suspected laryngomalacia. And they were treating them as laryngomalacia, and the kid was actually pretty loud, was really not gaining weight, was really not doing well. And so they referred him to me. And so I scoped the child and saw this massive follicular cyst. And this follicular cyst was completely obstructing the larynx. I urgently took this child to the OR and we marsupialized this. It ended up recurring, and we end up having to completely excise it under anesthesia. These can be really scary cases, especially in really small infants, and this is something you always have to be prepared for. But this really made me think, okay, what people think is laryngomalacia may not always be laryngomalacia, and these are the kids that need to be referred. And luckily, the primary care doctor did notice that this kid was just not doing well, which is oftentimes when we intervene. And so when do we intervene? So for me, I intervene obviously with all the normal things with laryngomalacia. It's failure to thrive. And that's for 2 reasons. Number one, their failure to thrive because their suck, swallow, breathe mechanism is disrupted because they're trying to breathe and suck and all those things at the same time, and they just can't get enough nutrients. The second is because they're working so hard to breathe, they're expending a lot of calories, and they end up actually losing weight. And oftentimes you'll see these really severe laryngomalacia kids, if they get discharged from the hospital, where they're like less than 5 percentile for weight and length. And those kids are really struggling. And so for me, there's really three big buckets. There's the severe, where they don't even get out of the hospital. They have to have surgery before they leave because their oxygen levels are dropping. They're just not gaining weight. They're not able to feed, a bunch of different factors. They're turning blue, things like that. There's the mild kids that are doing really, really well. They just have stridor. They're not having increase of worker breathing. They're gaining weight. They're feeding well. Those are the kids that I most often observe, and I don't usually use anti-reflux medications in that group because they're going to get better on their own. Most kids have physiological reflux within the first 6 months, which makes laryngomalacia worse, and we'll talk about why that happens. But after about 6 months, they're eating more upright, they're eating more solid foods, and oftentimes that goes away on its own and they don't need medication. Especially with all the new literature that's coming out about anti-reflux medications and some of the complications, I've really tried to avoid anti-reflux medications as much as humanly possible. And in the moderate kids, where I think there's about a 50-50 shot as to whether they're going to need intervention, sometimes I do use anti-reflux medications, or now we talk about pro-motility agents, to really push them towards not having surgery. There's some debate as to whether those children do go on to have sleep-induced laryngomalacia or other further problems down the line, and whether you should intervene early. We're not going to talk about that here, but really I'm very conservative about how I use anti-reflux medications. And the relationship between reflux and laryngomalacia is a precarious one. So when laryngomalacia happens, like we said, it causes a negative pressure. And as the larynx gets obstructed, the child has to breathe in more, which actually creates more of a negative pressure. That negative pressure is not only felt at the larynx, but in the intrathoracic area, where the negative pressure in the esophagus as relates to the stomach, which is now in the abdomen, which is actually seeing increased pressure, actually forces stomach contents into the esophagus. And as that makes its way to the upper airway and into the larynx, it can actually bathe and cause irritation, which actually increases the swelling in the larynx. And then that causes more obstruction and the cycle continues. This is why some people say reflux medication can help break the cycle. For me, time often breaks the cycle, or if needed, surgery will break the cycle. And again, I want you at home to really think about, is this inspiratory, expiratory, or biphasic? And I'll tell you, one way to really tell is listen to the exhalation phase. So it's almost like a seesaw. You can actually hear it going in and out, in and out. So this is actually a biphasic stridor. And biphasic stridor usually means that it's a static problem. It can be dynamic in the sense that the airway collapses on inhalation and collapses on exhalation for different reasons. And we'll talk a little bit about that when we talk about expiratory stridor. But essentially, oftentimes this could be a static problem, and it's usually at the glottis or the subglottis. And this is actually a picture of a child with with a inspiratory or biphasic stridor, and you can see on the left that this child actually has a pinhole. The slower this actually closes, surprisingly, the kids can actually look pretty healthy. And in fact, some kids, the stridor can go away because there's such minimal flow. And those are actually really scary kids. When you bring these kids to the operating room, you need to have a balloon ready, you need to have an ET tube ready, something to be able to open up that airway, especially in the early terms of the operating in terms of the operation. So to make sure that you can actually secure the airway. The kid on the right is more of a, you can see some lateral shelving and an elongated picture here. And oftentimes this is more congenital stridor, where the subglottis and the cricoid didn't form quite right, and they have prominent lateral shelving. Anybody who's intubated with this or gets croup or anything like that can cause some swelling and scarring that can actually make this worse. And these kids get stridor, and oftentimes we don't go into it here as to how we treat these, but the difference between the one on the left and the one on the right is often the one on the left usually responds very well to dilation, because the scar band can actually be divided with dilation, and some of the edema can go down. Whereas the one on the right, when you have a structural problem, oftentimes those are not as amenable to dilation, because the cartilage itself won't move with the dilation. So why is the subglottis most affected? And why is everybody always picking on the subglottis? And really it comes down to in infants and children that this is actually the narrowest point of the entire airway. And the other part of it is that it is a complete ring. For anybody who's watching Last Dance, this is also inspired by that. So the fact that it is a complete ring means that there's no give. Whenever there's any force that's provided against a surface, it's going to push back to the same extent. So when you have a trachea where the back wall is soft tissue or muscle, when pressure is actually exerted, it actually distends that part of the trachea, which can cause problems later on, which we'll talk about another time. But it has give. The subglottis does not have give. And it's a rigid structure that has a very, very thin lining that we'll show you. And what ends up happening when these kids get intubated and they're in the NICU or in the ICU and they're not sedated, which has been a very big push as of recent, in my experience, is that a lot of NICUs are not sedating children. You can have a lot of trauma, and I'll show you that later. The other is you can see the amount of subcutaneous tissue, and you can see here at the vocal cord level, these are the actual vocal folds here. You can see here, here's the conus elasticus, the part of the subglottis, and you can see here the tracheal rings as they start. So one of the things I want you to note is the thickness of the subcutaneous tissue. And so there's a lot of give here. There's fat, there's vessels, and there's actually a fair amount of give here that can actually take some of the trauma. Whereas in the subglottis, there's very little subcutaneous fat. There's basically muscles and mucosa, vessels and mucosa, and it's very, very prone to trauma as it gets pushed up against the rigid cricoid cartilage. And you can see here on this slide, here's the esophagus, here is the here's the subglottis. You can see a very, very thin layer of subcutaneous tissue. And when these kids are intubated and they are having tubes that are actually causing a lot of bumping, this is what ends up happening. So this causes a tremendous amount of trauma to the subglottis as the tube is bouncing around, and especially in the old days where these were cuff tubes and they were actually causing cuff damage to that area, it actually causes a lot of trauma, and that's why we see a lot of problems with kids that get intubated. And some kids are just more reactive than others. The other thing that we see sometimes in the subglottis is this, and I ask everybody to encourage themselves to find out, to think about what this is. So oftentimes this is a patient that you get called to the emergency room that has any kind of airway complaint. They did an AP neck, and they said that the kid has croup and subglottic narrowing. Now, most people who know kids when they're in the x-ray machine are actually crying. So this actually is not a subglottic narrowing. This is actually the glottis itself. So you can see here that these are actually the vocal cords approximating, and the subglottis is actually nice and open. As opposed to this picture where this is a true steeple sign. So this actually is subglottic narrowing, and you can see how long this area is, and you can actually see how narrow this actually gets. And this is a patient with croup. And croup is often a very common consult for us as otolaryngologists because some of these kids can get very, very severe croup, and oftentimes we get called in the acute phase. And I encourage you as residents to really understand when do we intervene with croup and when do we not. For me, croup is most often a medical disease, almost always. And it needs to be treated with supportive care, and it should get better on its own. The kids that I often see are, they have been given RACEMICs back to back for several hours. They've maybe have tried steroids, and they're just not getting better. And really what happens is, and this is where it comes down to the subglottis, is this is viral laryngotracheal bronchitis, meaning that the edema of the airway happens throughout the entire laryngotracheal bronchial tree. And why do they get stridor? Why do they get a barky cough? It's because the narrowing in the subglottis is not tolerated as well as other areas of the airway because it is the narrowest point. So you're actually creating a choke point at the subglottis, even though the same edema is happening throughout the laryngotracheal bronchial tree. And so they'll get that stridor, they'll get that barky cough. Oftentimes this is caused by parainfluenza 1 and 2, and they often will have stridor and a barky cough. Most kids will get better with supportive care. And so why do they get stridor? Again, it's a narrowing area. And what is the treatment? So we really rely heavily on steroids. I will say that a lot of facilities, both in emergency room and on the floor, really, really love racemic epi, or as we call it, RAC epi. And the problem with RAC epi is that it works really, really well in the short term. Now, RAC epi, just like any epinephrine, is a vasoconstrictor. And basically what's happening is, as they inhale the racemic epi, it causes vasoconstriction of the vessels in the laryngotracheobronchial tree. And basically you decrease the amount of edema just a little bit. And that just a little bit, like we talked about, is R to the fourth is the amount of resistance that gets dropped. So even if you just get a couple millimeters of room, that actually drops the resistance by 2 to the 4th power, and all of a sudden the stridor goes away. But the problem with racemic epi is that after about 20, 30 minutes, it wears off and that edema comes back, and sometimes it even comes back worse. And all of a sudden the stridor is back. And so the provider who's taking care of the patient says, oh, the stridor's back, let's treat him with another RAC epi. And then 10 RAC epis later, they're calling us to say, this kid has required 10 back-to-back RAC epis, and we don't know what else to do. So the first thing I say is that stop using RAC epi. People get very happy with racemic epi because it causes the noise to go away. And this goes back to my first point, whereas separate the child from the noise. The noise may be there, but if the child is not having problems, they're breathing okay, they're not having increased work of breathing, there may be stridor, but they're feeding okay, they're otherwise doing fine, their sats are fine, don't give them a racemic epi. Racemic epi is a temporizing measure, and it causes rebound edema. You only want to use it to temporize them while the virus runs its course, which is the same thing with steroids. Steroids, again, will decrease the edema and allow the virus to run its course, and they usually get better. And what I say is, when you're giving them 10 back-to-back RAC epis, all you're doing is chasing your tail. And every time that the racemic epi wears off, you're giving another racemic epi, and it just causes you to have this problem. And so the first thing I say is stop giving them RAC epi. If they are having trouble breathing, then you can give it to them. However, if the noise is there, don't treat the noise. And I usually give them steroids if they haven't already, and usually that will get them through it. The other is another temporizing measure is actually heliox. So this is actually part helium, part oxygen. And obviously the air we breathe is mostly nitrogen and a little bit of oxygen. And so helium is actually a much lighter gas than nitrogen. And this goes back to Reynolds number, which takes density into account. The lower the density, the less it is likely to cause turbulent flow. And as you can see here, that helium is a much lower atomic number than nitrogen, and it has a much lower atomic weight. And when you mix in helium within the gas, it actually is more prone to laminar flow. And when you have laminar flow, then you will actually have the stridor go away because the turbulence goes away. Now, again, this is not treating the underlying disease. All this is temporizing them. So I use heliox in kids that either we can't operate or they're really sick and we need to temporize them, or you need to get them to another hospital. And not everybody has heliox, but this is a temporizing measure and will not treat the disease, just like racemic epi doesn't. And this is different levels of heliox. So I think 70-30 is probably the most common. And you can see it has over half the density of room air. And you can see the Reynolds number as it goes down makes it more prone to laminar flow. And so when should we see them? You know, for me, if I don't think we need to see every single croup kid, either inpatient or outpatient. I say if it's recurrent, if this kid's had 2 to 3 episodes of croup, then we need to see them. If it's atypical, they are not following the normal, 2 to 3 day improvement. Also, if they're atypical as far as age, I'll tell you a story about an 8-year-old that I saw that had quote unquote recurrent croup that actually I think the kid was 5 years old, recurrent croup, and it definitely was not croup. And really the age should be that clue that maybe this is not just croup. And when it's not just croup, it can be a lot of other things, right? Anything that's affecting the subglottis in an acute phase can cause that kind of croup sound, can cause the barky cough and the stridor. On your left, you can see a subglottic hemangioma. We have greatly changed how we treat these. And really this is mostly treated non-surgically. And you can see again our lateral shelving. So some kids who get recurrent croup actually might have just lateral shelving of their subglottis, which causes them more prone to get noisy when they get a URI. It doesn't have to be true croup. They can just get a cold. Anything that's causing any kind of edema within the airway, for these kids who have congenitally narrow subglottis, you can actually get croup-like symptoms. And sometimes it's not croup per se. So this is the 5-year-old that I saw that was having recurrent croup, and they had had it 10 times in the past 2 to 3 months. And they've been seen at the urgent care and given 10 steroid bursts. And at some point, mom was like, you know what, I'm done. This is not normal. I'm gonna take my kid to an otolaryngologist. And she forced her primary care doctor to refer them to us. And when I saw the kid, he had obvious stridor, expiratory stridor, but he was actually doing pretty well running around the room. And it was quite obvious that this was not croup. It's not the right age group. Mom remembers a certain time when it started, and that was several months ago. And it just, every time he gets off steroids, it went away. So I went down and we actually explored this child's airway. And this is a video. And you can see there in the left main stem, you can actually see a peanut. And what had actually happened was about 3 months ago, this child had been eating peanut M&Ms, and mom specifically remembers an episode where the kid coughed. This is not the video from that child. This is actually a video from online. The kid that I saw had a lot more granulation tissue because it had been there for 3 months. And basically he had a half of a peanut that was down there for almost 3 months. And the edema would go down and his stridor would get better, but then the second it went away, it came back. This kid had so much granulation tissue that it actually started bleeding as we tried to take it out. What I ended up having to do was to actually leave this child intubated in the ICU and give him 2 days of steroids and then bring him back to get the peanut out, because otherwise it was just going to cause a bleeding mess. And this kid, you know, could have gone on for however long until he got a pneumonia and really caused a really bad problem. And the last thing we're going to talk about is bilateral vocal cord paralysis as one of the common causes of inspiratory stridor, or biphasic stridor. And so sometimes this can be inspiratory, expiratory, mostly biphasic. When kids are born with this, they have an immediate emergent airway if the cords are closed. And essentially, you need to intervene right away. And oftentimes these kids get trached unless you see a reversible cause. Every single infant that is born with biphasic stridor needs to have an MRI. And the reason why is because one of the major areas where both vagus nerves that innervate the cords actually get a common choke point is at the brainstem as it comes through the foramen magnum. And if you have a Chiari malformation, you can see here that there's a Chiari malformation, actually a syrinx as well, this fluid-filled pocket within the spinal cord. They actually causes compression on the vagus nerves as it comes through the foramen magnum and can cause the bilateral vocal cord paralysis. And the only other example I'll give to you is I had a patient that I saw, I think I was a fellow or resident, can't remember, but they came in with new onset biphasic stridor, and the kid was 9 years old. And the resident who came down and evaluated the patient, scoped the patient and said, I think it's a Laryngomalacia. And that obviously cued me, this obviously is not, I need to go check this patient out. So I checked the patient out, we re-scoped the child, and the child has a bilateral vocal cord paralysis that's new as of a few days ago. And so I inquired a little bit more about the patient's history, and it turns out the patient had a VP shunt. And so I asked the emergency room to actually scan the child and call neurosurgery to consider whether or not there was compression on the cord. And initially, neurosurgery had actually refused to come down, thinking that this was not a cause because the child was otherwise neurologically normal. Well, sure enough, the CT scan was done and it showed massive hydrocephalus that was caused because the shunt had malfunctioned, and she was actually having herniation, and that was the source of her bilateral vocal cord paralysis. They urgently took her to the operating room, revised the shunt, and magically her bilateral vocal cord paralysis went away and her stridor went away and she went back to normal breathing. So again, not everything is Laryngomalacia. So this is expiratory wheezing or expiratory stridor. This is actually what I heard in that child with the peanut because it was in the lower airway and actually was causing a little bit of a ball valve effect. And the etiologies of expiratory stridor, again, is again on the exhalation phase that there's actually collapse or narrowing of the airways. And oftentimes I see this in tracheobronchomalacia. And you can see here, this is the trachea, and you can actually see a very prominent indentation anteriorly along the tracheal wall. This is often a brachiocephalic or something along those lines that's actually causing dynamic collapse. And this can actually extend down into the trachea and into the bronchi, and they can actually have tracheobronchomalacia. And sometimes it can be so bad that even on inspiration, it collapses because of the negative pressure. And then on exhalation, it collapses as well because of the positive pressure that's causing intramural pressure that's actually collapsing the trachea. So this can be biphasic, but most often it's dynamic. Sometimes you don't hear it. Sometimes you just see it incidentally on exam. So other stridors, epiglottitis.
This boy was admitted to the intensive care unit 3 hours previously. He has acute epiglottitis. He's sick-looking, toxic, and lethargic.
So this is a very common consult that we get on the pediatric hospitals for kids with epiglottitis. And I'll tell you that children with epiglottitis, since we don't see them as much anymore, oftentimes people learn about it and just assume that anybody with stridor who isn't tolerating liquids has epiglottitis, or they go completely off an x-ray. And I encourage you again to look at the child and separate the child from the disease. Really, kids with epiglottitis are toxic. They are barely staying awake. They're tripoding. They look like crud. They look like they're going to crump any second. You don't see a kid with epiglottitis that's running around the room, yelling at mom, playing with toys. That is not epiglottitis. But we often get those consults because for whatever reason, they got a lateral x-ray and it showed some kind of thumbing of the epiglottis. And I'll tell you, oftentimes for kids that are totally normal and healthy, this is a incidentaloma. And oftentimes it's because they're seeing the folds of the epiglottis at different angles. And so it looks like it's thickened. So oftentimes, we talk to our ER colleagues, we talk to our primary care doctor colleagues and pediatricians to really say, okay, is the kid sick looking? We do still see epiglottitis. I've seen about 3 in my career, my short career so far, and these kids are really, really sick. And the way that we now treat them is the way that we used to treat them. Most of these kids actually used to get trached, but luckily, we are able to intervene by bringing them to the operating room. You don't scope them, you don't give them IVs. You basically do a very, very slow inhale induction with the parent in the room if they can, minimize disturbances, sometimes turn the lights off, and really do a very calm, slow induction. Because they're not exchanging a lot of air and their minute ventilation is actually very low, it actually can take up to 30, 40 minutes, even sometimes an hour to put these kids to sleep. The second they're asleep, you put an IV in and you actually try to achieve to get the airway. The most experienced person in the room should be getting that airway. If you can't get the airway, you start losing it. You need to think about surgical intervention. This is actually a scope exam of somebody with supraglottis. So you can see supraglottis in adults. Epiglottitis looks the same. Oftentimes big, red, and beefy. The whole supraglottis is actually very red and angry. And to actually touch this would actually cause even more edema, and it's friable, and these can be very, very scary cases for anybody. Other causes of stridor, obviously foreign body. So I think age is really a good tell. These are the kids that are toddlers that have had maybe a choking event or not. Parents looked away for a second. This can happen in younger kids. So, I've seen it in, 12 months old, if they have an older sibling that gave them something to chew on, just to see what would happen. And these can be scary cases. Other causes, complete tracheal rings. Some of us have seen these. Vikash, I noticed, just joined. I'm sure he sees a fair number of complete tracheal rings. So these kids sometimes present from outside hospitals. They were tried to intubate. Sometimes these are found incidentally during a surgery when they were getting some kind of surgery and they couldn't intubate them. These can be very scary depending on how small the kid is, because these can be as small as 1 to 2 millimeters, and we just don't have endotracheal tubes that get that small. But these actually can be causes. So in conclusion, I really want us to be critical about what noise you're hearing. Not everything that has stridor is laryngomalacia. Not everything is inspiratory stridor. Use your acumen. You know, when I tell residents when they're scoping, if you hear stridor but you don't see the laryngomalacia at the supraglottic level, don't just make it up. Don't just say that it's laryngomalacia. Actually listen to the sound when you hear the sound and when you see it. If those don't line up, then it's not laryngomalacia. It might be something else that you can't see further down. Really focus on the age. Try to get a really good idea of their history and their birth history. Get a look at the child. Are they struggling? Are they having problems? Listen very carefully to the sound. You can listen with the stethoscope over the trachea, over the bronchi to really get a good location of where the noise might be coming from, and really think about when is a good time to see these patients. You know, the recurrent croups, the atypical croups, the kids that aren't following the normal patterns, you know, things that stand out like a 9-year-old with stridor that get diagnosed with laryngomalacia. Think critically about these. You know, really be critical about a thorough workup. With that, I appreciate your attention, and I appreciate any questions you might have. And also, if you want to reach out to me, here is my email and my Twitter handle if you like. Again, no question is a stupid question. Thank you.
Thank you for that. That was great.
Of course. So feel free to email me any questions you might have. Otherwise, I will relieve my time to the very accomplished Vikash Modi.
Okay. Thank you.